Okay, it's 11:30, and I see that we still have lots of people just still joining us, but in the interest of time, we'll get started. And of course, we have a few announcements to make and some housekeeping to do before we get going. So we'll get started with that as people are still joining us. And as a reminder, you're able to print out your handouts from your control panel. And I want to welcome everyone to our webinar today, The Impact of Alzheimer's Disease on Swallowing. And these complimentary webinars are brought to us by Care Choices, Hospice and Palliative Services, Alzheimer's Orange County, O'Connor Mortuary, and Caring Companions at Home. And so, of course, we want to thank them. I also want to give a shout out to a couple of other people today who are responsible for the success of our webinars. One person is Michelle Shane. She is our behind the scenes technician coming to us every month from the East Coast. And she's the person who's behind the scenes, who's helping all of our attendees with their technical issues. And she works smoothly, silently, and efficiently when any of you are having problems with audio or any of the technical issues. And then I also want to give a big shout out to Laura Bronson, who is our webinar coordinator. And she's the person who works tirelessly to put all of these webinars together. She works seamlessly with our webinar speakers and works with all of you to get the CEUs that you need to make sure you get your certificates. She takes care of 1,000,001 different details, and she's just a wonderful resource for all of us. So I want to thank her. And I see lots of our regulars online with us. I see some new people. I can't fail but to give a hearty congratulations to two of our regulars, Jonathan and Kelly. Congratulations on the new baby. Now I want to tell you a little bit about our wonderful speaker today. She is Maria Quincy, and she is a licensed speech language pathologist who has worked in a hospital setting for over 25 years, evaluating and treating adults with communication, cognitive, and swallowing disorders. So she holds a Master's of Science in Speech Language Pathology from Boston University, a Bachelor's of Arts in Speech and Hearing Sciences from UC Santa Barbara, and a Certificate of Clinical Competence in Speech Language with the American Speech Language Hearing Association. In 2014, she published her cookbook, Think Outside the Blender, Great Tasting and Healthy Recipes for Dysphagia Diets. She's had several articles that she's published online, including an article featured in in California Speech and Hearing Association magazine, summer 2015 edition, called Modified Diets in the Acute Care Setting. She's presented internationally and also to the Alzheimer's Association, Parkinson's disease support groups, and stroke support groups. She hosts a podcast called Caregiving Challenges and Solutions, and that's available on her website and Apple Podcasts. Her goal, which is a fabulous goal, is to improve the quality of life for people living with dysphagia so that they can enjoy their food and eat with dignity. And also, her goal is to provide information and resources to caregivers to help them navigate their day-to-day challenges. And so I had the pleasure of working with Maria last year, and I actually was able to be a guest on her podcast. And I really just have so much admiration for her, and I'm just thrilled that she is our presenter today. So Maria, welcome to our webinar, and I am going to go ahead and turn it over to you with great pleasure.
Great, thank you so much. Well, good morning, everyone. I have a lot of information to share with you today, so I'm going to jump right in. So dysphagia, you may also hear it pronounced dysphagia. Where I went to school, they taught us dysphagia in order to differentiate it from dysphagia, which is Dysphasia, which is actually a language disorder, but you'll hear both pronunciations used. And it basically means difficulty swallowing or the inability to swallow. And there are many causes, for example, stroke, head injury, head and neck cancer, anyone who's had surgery and maybe a prolonged intubation that can really irritate the throat, the presence of a tracheostomy tube, lack of or poor dentition. Now, some people have no teeth and they do great. It's always amazing to me. Some people have dentures and they don't fit well and they hurt, so they just don't wear them. Also, several progressive neurological disorders such as Alzheimer's, dementia, Parkinson's disease, and these can lead to weakness over time and cognitive deficits that can affect the swallow function. And also just someone who's generally weak, maybe they have a lot of other medical issues going on and they have a decreased level of alertness. I always tell people the #1 rule is you have to be awake to eat. And that might sound kind of silly, but you'd be surprised how many people try to feed their loved one and they're not awake enough to eat. So we're going to go over the normal swallow function, and it occurs in 3 phases. We have the oral phase, which is food or liquid in the mouth, the pharyngeal phase, and pharyngeal or pharynx is just a fancy word for throat. And then we have the esophageal phase, and the esophagus is the tube that goes from the throat to the stomach, and it's where the food goes down. So we'll take a look at each of these in a little bit more detail. And I know this image here is a little bit small, but you can see a side view of a person, and the green stuff is the food or the liquid in the mouth. So during the oral phase, you take a sip or you take a bite of food and you start chewing, and that activates extra saliva production. And as the food breaks down, your tongue starts to form this food into a little ball, or what we call a bolus. Then the tongue moves that bolus towards the back of the throat, and when it gets to the area about the tonsils or a little bit farther, then that triggers the swallow reflex, and now we're into the pharyngeal phase. And there are several things that happen during the pharyngeal phase. So the larynx, or the voice box, will lift up and move forward a little bit, and that causes a couple of things to happen. There's a little piece of cartilage at the base of the tongue called the epiglottis, which you may have heard of. That flips down, and at the same time, the ring of muscle on top of the esophagus, which is normally closed, that opens up and allows the food to enter the esophagus. Also, your vocal folds close. They move together as a protective mechanism in case anything were to go towards the airway. And this all happens pretty darn quickly. Once the food enters the esophagus, we're into the esophageal phase. And once that happens, the inner lining of the esophagus, those muscles start forming this peristaltic wave action, and it helps push the food down towards the stomach. And we swallow about 1,000 times a day. I think it's something we totally take for granted until it's something we can no longer do. So I invite you the next time that you're going to take a drink or take a bite of something, just take a moment and pay attention to what's going on in your mouth. How does it feel when you swallow? And notice how fast it is. So that's what happens on a good day when everything's going correctly. But there's a lot that can go wrong. So let's look at each phase here. So during the oral phase, a person might have trouble chewing. Again, this could be due to poor dentition, or for someone recovering from a stroke, they might have numbness or weakness on one side. So you might get pocketing, food or liquid that gets stuck in the mouth, maybe under the tongue or in the side of the mouth. I had a lady several years ago I was working with in a skilled nursing facility, and I went to see her about 11:30 in the morning, sat her up, looked at her mouth, scrambled eggs from breakfast. So it's not a safe situation, because if you go and lie down with food in your mouth, it could potentially go down into the airway. Also, if you're not swallowing your secretions, it's likely to be pooled and then dripping from the mouth. So in the pharyngeal phase, if you're noticing a cough before, during, or after the swallow, that means probably that voice box isn't lifting up as quickly as it should, or as far as it should. You might also have food or liquid being a residual in like the base of the tongue or different pockets in the mouth. And those are risks, a risk of aspiration, which we'll get to in a moment. In the esophageal phase, I often get the complaints of people feel like food is getting stuck. So that peristaltic wave action isn't working as it should. So aspiration means food or liquid that enters the airway, so it actually goes below the level of the vocal folds into the trachea, into the airway, and potentially down to the lungs. And the signs of this are someone who's coughing or choking during a meal, whether it's liquids or solids, or when they're taking medications. If they sound like they have a wet or gurgly voice, kind of like that underwater sound, that tells me that whatever they've just tried to swallow is sitting right up above the vocal folds, and that's what's causing that wet quality. Or even just someone who has that just that frequent throat clear every time when they're eating. It's something's heading down the wrong pipe, so there really is a wrong pipe. Or even someone who has watery eyes, or someone who's getting recurrent pneumonia. Now, silent aspiration is when the food or the liquid goes into the airway below the level of the vocal folds, but it does not trigger that cough reflex. And you wouldn't know this unless it was identified on an instrumental exam. So we'll take a look at that too. So how do we evaluate a swallow? Well, the basic bedside swallow evaluation is where I would go in, as long as the person is alert, and I would give them various consistencies, maybe a solid, a puree, and a couple of different liquid consistencies. And I assess, are they able to manage the food in their mouth? Is there any drooling? Is there any pocketing? Does the swallow happen quickly? Are there any overt signs of aspiration? And if I feel like I need more information, I might recommend an instrumental exam. So the modified barium swallow study is done in the radiology suite in conjunction with the radiologist, and it's basically the same thing. We give trials of different consistencies, but we have the fluoroscopy running during the swallow, and so we can see where the food or liquid is going. It has a little bit of contrast, barium added to it, so we can see, is there any aspiration? Is it silent? Is it overt? The FEAST study, the fiber optic endoscopic evaluation of swallowing, that's a mouthful, that gives a completely different view. There's a little tiny camera put on the end of a tube that goes up through the nose. They numb you first, and it sits right above the throat, and it gives you a great view of the anatomy of the throat. Again, swallowing different consistencies, and it just gives different information. So how do we treat our dysphagia? Well, we might try some exercises if there's muscle weakness, and these could be exercises that are specific for the swallowing mechanism or the face. NMES stands for neuromuscular electrical stimulation, and there are just tiny little electrodes placed along the throat, and it's used in conjunction with swallow therapy. So when the person goes to initiate or trigger a swallow, the electrodes just give you a little bit more support to help the muscles contract and strengthen. We also use diet and liquid modification. Changing the texture of solid foods or the liquids can make it easier and safer for people to eat, and also compensatory strategies. So let's take a look at compensatory strategies. So you'll also hear these referred to as aspiration precautions. So there's strategies and precautions that are used during a meal or when taking medications to help make it safer to eat and to swallow. And they're compensatory because they help compensate for a weakness or even a cognitive deficit. So again, my number one rule, right? You got to be awake and alert to eat. Ideally, sitting as upright as possible is great, 90 degrees for sure. I know that's not always possible. I had a doctor one time order a swallow evaluation for a lady who just had back surgery and she needed to be flat for 12 hours. Luckily, she could lift her head a little bit and turn and sip water through a straw. Was it ideal? No, but it's what I had to deal with at the time. Also, eating slowly, one bite and sip at a time in small amounts is usually safer than, chug-a-lugging a lot of water at a time. Also, limiting distractions. If you're working with someone who gets easily distracted, try turning off the television, maybe go to a part of the dining room that's a little bit quieter. Alternating liquids and solid foods can help with pocketing. That helps to clear any residual in the mouth. Those straws, some people, again, they have trouble with straws because they might take a lot and get that large volume of liquid at the back of their throat. Other people use straws with no problem. Sometimes if you're assisting the person, you can actually pinch off the straw so you can control the amount. And another strategy is having someone there to assist if the person is not able to eat All right, so just a little bit about diet and liquid modification. So we change, again, the diet texture and the liquid texture to make it safer and easier for someone to eat. And you may be familiar with the National Dysphagia Diet, and that looks at 4 different areas or 4 different levels. For example, level 1 is pureed, level 2 mechanically altered, level 3 advanced, and level 4 regular. And this came out almost 20 years ago, and I think their main idea was to try to get some standardization in terms of language and labeling. However, every place I've ever worked has very liberal interpretation of what these levels are. These foods can go here, but not here. And um, it was always very individual depending on where I worked. So the new kid in town is the IDDSI, and that is another mouthful, International Dysphagia Diet Standardization Initiative. And this has been around for a few years, and they've actually taken food and liquids and put them on the same scale from 0 to 7. So let's see what that looks like. So they start with level 7, regular foods, and gradually work their way down all the way to 0, thin liquids. And from regular, they gradually get soft, bite-sized, minced and moist. And the interesting thing with the IDDSI here is level 3 and 4, where there's some crossover. So level 4 under foods, pureed, they equate that to level 4, extremely thick in liquids. And this would be what I would call a pudding thick liquid, like a liquid so thick you could stand a spoon up in it. And then we have level 3, the liquidized under foods, is the same as moderately thick liquid, which I in the past would call honey thick liquid. And then we have our mildly thick, which you might be familiar with, a nectar thick. And then slightly thick would be like a milk or an Ensure or a Boost, because they are slightly thicker than thin, which is 0, which would be like your water, your tea, your coffee. So if you haven't seen this yet, I think a lot of places will be transitioning into this labeling system. I'd like to switch gears a little bit and talk about how Alzheimer's disease can affect swallowing. So we're going to just talk a little bit about the mild, moderate, and severe stages and what you can expect to see. So just in the very beginning stages, a person is not likely to have any like mechanical problems with the oral or pharyngeal phase, but this is a person that I'm seeing with memory problems, and I'm more worried about them going into the kitchen and turning on the stove and then walking away and forgetting it. So more safety issues, but they also might start having changes in their food preferences. And this is a person who maybe they're living in a memory care facility community, and they might express concern. Oh, I need, is this paid for? So you might see that. And as we move along into the moderate stages, now the person's starting to need a little bit more help. They actually might not know which utensils to use or know how to use the utensils. For example, I'll often give someone a cup of applesauce with a spoon, and they'll try to drink from the cup instead of actually using a spoon. Also, these folks may not recognize when they're hungry or thirsty, so they may not initiate asking for something to drink, which potentially could lead to a dehydration. This is also the stage where these folks, they don't want to sit down and eat. They're up and they're walking around and they're busy. So, maybe they're not eating as much as they normally would. And in the advanced or late stages, now we're seeing someone who needs round-the-clock care, assistance with their ADLs, activities of daily living. And now we are starting to see changes in the physical condition, which can affect muscle weakness, but also decline in cognition. So a decreased awareness of food in the mouth, like the lady I mentioned with the scrambled eggs. And at this point, they may also be refusing to eat or drink. And you especially are probably going to notice difficulty swallowing whole pills. And at this point, they're also becoming more vulnerable to things like aspiration, pneumonia, and other infections. So what can we do? Well, lots of things, especially in these earlier phases, providing written reminders, 12 o'clock, it's time for lunch, really creating a home-like atmosphere in your dining room, wherever that may be, offering a lot of reassurance, and just serving food to people as soon as they are seated. Also using finger foods for that person who doesn't want to sit down, maybe they can pick something and take it with them when they're on the go. Again, limiting distractions, like we talked about, turning off televisions, finding a quiet area of the dining room, offering ethnically and culturally appropriate foods if you can. And I like this one, to seat individuals according to compatibility rather than disability. So just like you have people you would prefer to eat with and maybe not so much, the same goes for our patients and our residents. So during the late stage, we're actually going to spend a little bit more time looking at each of these things: diet and liquid modification, and this includes medications and supplements. ONS is oral and nutritional supplements, like your Boost and your Ensure. Food and liquids for oral gratification, assisting people with eating, oral care, and also looking at patient and family wishes regarding end of life and feeding tubes. So this is my favorite section. This is dining with dignity. And to me, when someone gets to the point in their disease where the pureed food is what's safest and what's easiest for them to eat, I feel like the whole dining experience is just not very dignified. So this was probably what might show up on your lunch tray. And what you'll notice, I hope, is that everything's kind of the same color, the same shape. The only thing you can really identify there is the mashed potatoes. The green, it could be broccoli, it could be peas, we don't know. The meat there, it could be chicken, it could be turkey, it could be fish. We don't recognize it. And there's that saying that we eat with our eyes, and it's so true, right? So this to me is just, it's not appetizing. I'm happy to tell you that there are some simple things we can do to improve the situation. In fact, there are chefs around the world, in Europe, in Japan, in Australia, who are working on ways to create appetizing food. In fact, I recently got an email from a chef in South Africa. He wants to start creating food for people with dysphagia. So I'm going to show you some pictures of pureed foods that I think are quite appetizing. So offering a variety of colorful foods and foods that you can recognize, right? So here we have watermelon and the honeydew. I'm not sure what the middle one is. And the outside is the rind of the melon, but the inside has been scooped out and blended, and a little bit of a gel has been added to it so it can retain its color and its shape. And there we have some cheddar cheese. So you look at that, it's colorful, it's bright, you know what it is, it looks appetizing. And there we have our chicken and some strawberries. And I also have to say that the food molds have come a long way, and they're very realistic. So I know these may not look like your typical pureed foods, but they actually are that level 4 and level 3 on the IDDSI framework, because when you put them in your mouth, they require very little tongue pressure to break down. And here we have some carrots, and the carrot sticks on the left side of the plate are carrot sticks, and the ones on the right I made using this gel, but you can see how easily the fork presses through them. But it could also be a finger food. You could pick it up and take it with you. And the chocolates, those are my favorite. Again, they'll break down. And here we have a ham sandwich. So my friend Gabriel Serrero is a chef in Switzerland. He specializes in molecular gastronomy. He's the one who created the gel to create all these foods. And he was taking some samples to his local skilled nursing facility, and the staff said, we've got this gentleman, he's on a pureed diet, but he doesn't want to eat any of the food. And Gabriel said, well, what does he like? And they said, a ham sandwich. So Gabriel figured out how to do the bread, the lettuce, the cheese, the ham. The black layer in there, I believe, is like an olive spread. And so he brought it to this gentleman, and he ate the whole thing. He was very happy. So I just want to show you what's possible in terms of diet modifications. So some other suggestions for creating a more dignified dining experience is to make it social. We have research to show that the more people that are gathered around a table, the more we tend to eat. So this wouldn't be for the person who needs or doesn't like the distractions, but getting people together. Using red dishware. I think it's the contrast between the food and the color red. We see people tend to eat a little bit more. Also, using dining scarves instead of towels or bibs. I'm actually wearing a dining scarf. So if you think about our residents in skilled nursing, for example, they get wheeled up to a table, they get a bib put on them, and they get fed by a spoon. Well, who wears a bib and gets fed by a spoon? babies. So, these are adults. Let's treat them as such. And I love these dining scarves. They come in different colors and different fabrics, for men, for women. I mean, this is something you can wear out to a restaurant and it looks much more elegant. I also invite you to be aware of the language that you are using and when referring to people who need assistance. If you remember anything from today, please do not use the word feeder. Strike it from your vocabulary. I would much rather you use something like a dependent diner or someone who needs assistance with eating. The word feeder to me is very disrespectful. And if you are the person who is assisting your dependent diner, you are following your aspiration precautions and your compensatory strategies. All right, so a group of residents in a nursing home was asked what was most important to them in their daily routine. And I have to say, this was a little surprising to me at first. Having their hair combed and their teeth brushed. And if you think about someone who's living in a memory care community or skilled nursing, once they leave their room, they're out in public. So think about, would you walk out your front door without fixing your hair and brushing your teeth? Probably not. Well, it turns out there's more to it than just maintaining dignity and keeping up self-esteem. Having regular good oral care is actually very important in reducing the risk of aspiration pneumonia. All right, so we're going to spend a few minutes talking about oral care. So this was a study done a while back by Susan Langmore, and she looked at almost 200 people across various settings, skilled nursing, inpatient, acute care, and she wanted to find out what were the factors that were important for someone to develop aspiration pneumonia. And dysphagia was there, but she found that the top 3 factors were if someone were dependent on someone else to help them eat, to help them with their oral care, and number of missing teeth. So if we can address these top 3 things, we can greatly reduce the risk of someone developing aspiration pneumonia. And just another study by Yonayama, he found that oral care after meals for people with and without teeth resulted in a significant decrease in rates of pneumonia, febrile days, that means having a fever, and death from pneumonia. So it's super important that we help those folks do their oral care, especially if they cannot do it themselves. So the goals and benefits of oral care: maintaining oral cleanliness, preventing infections. We want to keep the inside of the mouth nice and moist and promote comfort. And I know there's a lot of folks out there who, they sleep with their mouth wide open. It's like the Sahara Desert in there. Their tongue looks like sandpaper, but we just do the best you can to keep the moisture in there. Here's just a very basic recommended protocol: brushing twice a day after breakfast and dinner. The electric toothbrushes are great. They do the work for you. Remember to brush the tongue. You can use those little swabs to remove any like dried secretions or debris. If you've got access to oral suction, great. It works really well for removing, again, anything that was loosened up during your brushing. Dentures, if you have people that have dentures, please remove them and clean them before you put them in the solution. Oh my gosh, there's so many times I walked into a room and I see that denture cup on the sink and I open it up, and obviously the dentures have not been cleaned. They've just been put in there and filled with water. So they really, really, really need to be cleaned. They require the same care as teeth. Those little swabs, the little spongy things on the end of a stick, those are okay for maybe moistening the mouth, but they don't take the place of good oral care, and they are one-time use only. Do not use them in someone's mouth and put them back in a cup of water at the bedside. I've seen it. It's gross. Just use it once and throw it away. And I had a patient many years ago who was a retired dentist, and his favorite thing to tell me was, be true to your teeth and they won't be false to you. So I will always remember that. And I wanted to talk a little bit about tube feeding. When someone continues down the course of Alzheimer's and dementia, they are probably going to get to the point where it's either not safe for them to eat or they're not eating enough to sustain their nutrition. And so the family members may be faced with this decision of whether or not to place a feeding tube. So we'll talk a little bit about that. So it just basically is intervention that delivers fluids or nutrition in a means other than by mouth. So we have an NG, nasogastric tube. That's the tube that goes down the nose through the esophagus into the stomach. Very temporary. At least I would hope they would be very temporary. And I mean like a week or so. I know they're often left in longer than that, but that's my recommendation. The G-tube, you'll also hear this referred to as the PEG. That's when a little hole is punched in the stomach and we attach a tube, and then the liquid food is delivered through that route. The J-tube, similar to the G-tube, but it's just placed in the jejunum a little bit farther downstream. Again, liquid food is put through the tube. And then we have our parenteral, our TPN, and our PPN, which is nutrition delivered via a catheter placed in a vein. The doctors don't like to use the TPN, PPN if the gut is working. So if the gut is working, it would be one of the first three options. So who can benefit? Well, anyone who's recovering from early head and neck cancer who has a good prognosis for recovery, but maybe they just need a little bit of extra time before they can start tolerating food by mouth. Someone who's had an acute stroke, and this would be someone who was generally in good health prior, who was fairly independent, someone without a lot of other medical issues, again, with a good prognosis for recovery. We're just buying them some extra time until the swallowing function can return. And then someone with GI issues or bowel obstruction. So some of the benefits of tube feeding, it may prolong life with certain populations, but it may not improve quality of life. And I really want you to keep that in mind. It's a very important issue. It can enable family members to maintain hope for future improvement and avoid guilt associated with choosing other options being not placing a feeding tube. It can also give people just time to adjust emotionally that, the person is entering the final stages of life. But it also can allow a means of providing medication. If a person is no longer able to swallow medications by mouth, they may be able to be given through the tube, and that can greatly affect a person's quality of life. So what are some tube feeding complications? When I say there are too many to list, I'm not kidding. This article probably listed 30 or 40. So I'm just giving you a few that I picked out. You can have pain at the tube site. Some people don't tolerate the liquid nutrition, which can cause the nausea, vomiting, diarrhea. The tube can cause a tear in the lining of the esophagus or the stomach. You can have fluid overload, and we'll talk a little bit in a minute about, as someone gets towards the end of life, your body's systems start shutting down, so you don't metabolize that fluid, and having too much fluid can actually have negative consequences. Also, loss of dignity and the need for restraint. So think about if you have a feeding tube in someone, but you need to restrain their arms and your hands, what kind of quality of life is that? Is that something you would want for yourself? And unfortunately, there's death. So this is a really interesting article that came out, again, about 20 years ago. And looking at this list, you would think logically, well, if you're providing nutrition in a means other than the person having to swallow it, it should prevent aspiration of ammonia. You would prevent malnutrition. You'll help, improve or prevent pressure ulcers and other infections. Well, they did a survey of about 30 years of research, and they were looking for any evidence to see if these things were true. And this is specifically for people with advanced Alzheimer's. And they found no evidence to support any of these things, which I think surprised a lot of people. In fact, they said the most common adverse effect associated with all types of tube feeding is aspiration pneumonia. And for PEG or G tubes, the most common adverse effects are tube occlusion, leaking, and local infection. Just something to keep in mind. So how do you decide? You're faced with a decision, the doctor's saying, we have this option, we can put a feeding tube. Well, we first want to look and see if the person has an advance directive. Maybe hopefully they have put their wishes in writing. Yes, I want everything done to prolong my life as long as possible. Or no, I don't want any artificial nutrition or hydration. Or maybe there's something in between. If there is nothing in writing, then it's up to the decision maker to, hopefully know what would that person have chosen if they could say. And then it's always really good to have a family meeting with your doctor, your nurse, your speech pathologist, dietitian, social worker, and really come to an agreement on what is in the best interest of this person. In your references, there's a really good handout from the Coalition for Compassionate Care of California. I think this is an old version, but I really like it because it goes through some really commonly asked questions, and it doesn't use any fancy medical jargon. It gives you very simple, clear answers. So you can just do a search for that and find that decision-making guide. So now we're going to talk a little bit about comfort feeding and oral care, and this is really, I'm sorry, oral gratification. And this is really for the person who's not taking any nutrition, maybe they can't or they're refusing. We're really talking about getting toward that end stage of life. So for the person who really can't tolerate food to maintain nutrition, the goal is not to give food or liquids for nutrition, but just to provide comfort, to give a little bit of flavor in the mouth. So maybe a little ice chip or two, and I don't mean like a spoonful of ice chips, literally 1 or 2 ice chips that can provide some moisture, having that coolness on the tongue, maybe just a little piece of popsicle or a lollipop. And maybe a small amount of their favorite food, maybe a little ice cream or something. And again, the goal is not nutrition here, it's just to provide some comfort. If someone is completely NPO, that means nothing by mouth, they may benefit from an artificial saliva. I know these come in spray in different forms. And there's something called Xylamelts tablets. I recently learned about this from one of my patients who was recovering from head and neck cancer. Her mouth was very dry. And they're these little tablets that you stick on your gum or your tooth before you go to sleep. And then overnight, they gradually dissolve to help keep the moisture in your mouth. And at this point, you are going to need to look at a different route for medications. If in fact medications are still available, I definitely would talk with a doctor, or if you have hospice involved, ask the hospice nurse, what medications are we still even needing at this time? And are they available in a different form, such as a patch? And of course, keeping up with your oral care. So this is from Pollen. She's a speech language pathologist who has done a lot of work on hospice and end-of-life care. So the significant decline in swallowing may signify that the person is kind of entering that time of active dying, end of life. And it's so important to help families understand that the person's not eating is no reflection on their lack of skill or lack of caring. And so emphasizing what can be done. Maybe they can sit with their family member, read to them, listen to their favorite music, put some lotion on their hands. And I just wanted to read to you a line. There was a letter to the editor that was a follow-up to that study about the feeding tube myths. And this is from a medical doctor. And he says, it's easy to lose sight of the fact that not eating, may be one of the many facets of the dying process and not the cause. So I think the more we can help family members understand that, the better. So like I mentioned earlier, having fluid overload can have negative consequences, but when people really get towards that very end of life, they're not experiencing hunger or thirst, and being a little bit dehydrated at that time can have some benefits, such as a sedative effect and maybe some comfort. You're going to have reduced swelling, reduced secretions. Again, that's a more comfortable place to be than having that fluid overload. And this by Roe and George. So again, just making sure that family members are educated and understand the course of the disease, and it's going to be helpful for them also. And one of my favorite quotes, you cannot pour from an empty cup. Take care of yourself first. So I think being a caregiver is probably one of the most physically demanding and emotionally challenging things you can do. So don't try to do it alone. Reach out, get help, find resources, and Alzheimer's OC is a great place to start. So that's what I have for you. I invite you to email me with any questions. We are going to open it up for a few minutes of questions here live. If you do email me, please put webinar in the subject line so I know it's a real question and not spam. I have a lot of resources on my website, And of course, you can check out my podcast.
Great. Let's go ahead and leave that last slide up, Maria,
Sure.
so that people have access to you, because I know we have some questions from some of our attendees, but I want people to have that opportunity to reach out to you and to know about your resources. This has been just a very helpful presentation, I know, for
Yeah,
all of our attendees. And so we thank you so much, Maria.
you're welcome.
Before we begin the Q&A session, in case we run past 12:30, I just want to just take this opportunity to thank our sponsors again, because it's because of them that we can offer these free sessions, which is such a great benefit for all of our viewers. So thank you again to O'Connor Mortuary, Care Choice Hospice and Palliative Care, Caring Companions at Home, and of course, Alzheimer's Orange County. We have another great seminar lined up for next month. It's going to be on the topic of sundowning and dementia, and we'll have Erin Light, who is the administrator at Silverado Senior Living in Costa Mesa. She is going to be with us, and she's a gerontologist, and she has over 10 years of experience in dementia care. So another great topic coming your way next month. So just a reminder to everyone that if you're getting CEs, you must stay online with us for a full 60 minutes. We're at 12:20 now, and so stay with us. And let me take a look and open up our question box and see what questions we have for our wonderful speaker, Maria Cuisi. Okay. Oh boy. Where do we start?
Oh,
Can you talk about saliva buildup and drooling near end of life? Do you recommend using suction? Great question.
I would say if you have it, yeah, but you don't want to be in there, all the time suctioning saliva out. Part of it has to do with positioning, making sure someone is upright. You might even just want to have a towel or something handy. But if you have suction, I would say it's good to use it periodically for sure, unless
Is
it's
it
like really really
is it
bothering
too
the person.
is it invasive if you do it too frequently? Is that what you're
Yeah, I would just
saying?
worried about it doesn't feel, it might not feel good to have something in their
Oh,
mouth, poke it in their mouth too often, but I say, periodically for sure. Yeah.
okay. But is it harmful for them to have that and swallow it? I'm sorry, I don't mean to keep probing.
No, no.
Okay.
Well, if they look like they're about, they're swallowing it and that causes a coughing episode because it's being aspirated,
Okay.
then, again, that's why I want them to be upright and probably not reclined so much, but upright is going to allow the saliva. If it's coming out of the mouth, so be it. We'll wipe it up. We'll use our suction. So,
Okay. Thank you.
yeah.
Let's see. How do we maintain oral care when the resident won't cooperate and is actually strongly resisting?
Yeah. I would say get creative. uh, Maybe try to find something that they will be cooperative with. Maybe it's a certain type of toothpaste, or if they're absolutely refusing the toothbrush, maybe they'll be more cooperative with the little swab. It's not ideal, but maybe you could even have the swab in a little something with some flavor in it, just to get moisture in there. That's a real challenge. I understand that, and maybe have someone work with that resident who that resident likes. Um, you know,
Yeah,
that's a
I
tough
mean,
one.
that's the $1 million question. And I don't know, sometimes it has a little bit to do, it can have something to do with your approach, right? I mean, if you're in a hurry and that kind of transmits that anxiety kind of transmits itself to the resident, sometimes you just have to really approach from the front and
Yeah,
be
and maybe start with something
reassuring,
else,
take your
brushing the
time.
hair, washing the
Yeah.
face, and then
Oh,
maybe you
good
could
idea.
sneak it in.
Yeah, it's not easy though, right? Especially when you have a whole bunch of residents that need your attention. My sympathies.
Yeah,
That's a tough one.
yeah, I understand.
Yeah, but I mean, wouldn't you sort of pick your battles with that, and maybe even if you can just get them to rinse,
Absolutely,
would
absolutely.
that be better than nothing, or to
Yes,
chew on a swab, or I don't know. That's a really
yes.
tough situation.
Yeah, if you're trying to force someone into doing oral care and it's making them even more aggravated, I would just leave it. Just,
Yeah, and maybe try again another later, or try
yeah,
another, get a staff another staff person to try, like you said,
yeah,
someone
sure.
someone they like better.
And and
Yeah,
you can't take it personally when someone seems
right.
like they don't like you. It's not you.
It's their disease process, right?
Yeah.
Right. Okay. Right now, I'm currently dealing with a resident where they're no longer eating and they've lost 50 or so pounds. Hospice is involved. Is there anything I could do to help? And is there anything for the spouse?
Yeah, so I'd want to know, are they not eating because they physically can't? Is it like a real severe dysphagia, or are they refusing? I think this is sounds like a time for a family meeting, for sure. Get the team together, look at where is this person in the course of their disease. That's a huge weight loss. What are the next steps? What are the options? But you would probably need to get the medical doctor, nursing, dietitian, social worker involved, and for sure the spouse to find out where to go from here. Yeah,
Yeah,
family meeting.
yeah, yeah. And how kind of you to be concerned about the spouse as well, because as we all know, in hospice, both the patient and the caregiver are one unit of care. So that's very kind of you to be concerned.
Yeah.
And you said something, Maria, I was touched by when you were talking about in the end how we all want to feed people, and that's because that's our culture. Food is love, and at the near the end, I mean, it's just really not needed, and that's so difficult for us because we want to sit at bedside and offer food, and that's just
I, hey, I come from a
it's
big
built
Italian
in. It's built.
family. I know.
You
I
come
know
from
in
what?
a big Italian family, so I get the
Right.
whole thing about the food. In fact, my grandfather had Alzheimer's disease and was cared for at home by my grandmother for years. And I
Mhm.
remember her just, lifting his head up off the pillow to offer a little sip of wine, and I don't think it was for him. It was more for her, to feel like
Yeah.
she could do something.
And
So
food is a social activity, and when people are in bed, there's so little they can do. So it's a really tricky subject, and I don't know. I mean, I'm going to go out on a little bit of a limb here morally and ethically, but I do believe, this is just my personal belief, but I do think that people are, even in Alzheimer's disease, are able to stop eating because they're just ready to stop.
mm-hmm.
So, who knows with this particular client what's going on, whether there's a physical reason they're not eating anymore, which can be addressed, or whether they've lost the will to live. I mean, it's just so, or whether they've just forgotten how to eat. I mean,
Yeah,
there's so many variables,
right.
and as caring people that we all are who are on this webinar right now, it's so hard to parse through all of that and try to decide, make the right decisions for the people we care for.
Yeah,
So it's a tricky subject, definitely.
yeah.
Let's see. Can we have feeding tubes in RCFEs and boarding cares?
Huh. I
I,
want to say yes, but I actually don't know for sure, so maybe I'm not the best person to answer that question. I know in skilled nursing they can, I believe.
so there are RCFE people online with us now.
Sure.
My sense is that you'd have to get a waiver for that, and that they would have to be temporary. So let's ask someone like Kelly or someone Estelle, some of our RCFE people to put something in the chat box for that. And let's go on to the next question in the meantime, which is, what is the research for the statement that most people do not experience hunger or thirst as they are dying?
Uh, I can send you the link to my reference list. That's I don't recall the particular author off the top of my head, but I can send you that information.
Yeah, I think there's a body of research around that. I'm going to take a stab at this myself. I think for me, it was always understood that this was the case, that the body creates sort of a natural type of endorphins. It's like a natural morphine
Mm.
as people begin the active dying process, that they no longer experience pain or hunger or thirst as they start to transition.
Mm-hmm.
That sounds pretty anecdotal, but I think there's research to back that. So
Yeah,
we can look into that for you.
yeah.
Okay, what else? If someone is living at home, do you have suggestions for how to make their pureed food look just like the ones in the pictures that you have?
Well, one of your handouts is called Think Outside the Blender, and that's just a list of techniques that I've come up with to, yeah, for the person at home who's making pureed food, just some simple things you can do to make the food look more appetizing. If you want to learn more about that particular product that was used to make those the foods in those pictures, it was my friend's company is called Emotion Food Company, and he's out of Switzerland, so you can do a search for that and learn more. But the handout on Think Outside the Blender gives a lot of suggestions on how to create food at home that certainly looks more appetizing. So.
Okay, not a question exactly, more of a comment, but with COVID-19 and people being on respirators, some for extended periods, I would think those who survive might well require help in this area. So sort of talking about a new market for your expertise.
Yeah, the patients that I've worked with thus far that are recovering from COVID, some of them that are more impaired from a respiratory standpoint will need a tracheostomy tube, which can of course affect the swallowing. But I've worked with several people who have not. And once the tube is out and after a few days, they can usually resume a regular diet, or maybe starting with softer foods and then gradually working their way back up. So yeah, we're definitely going to be seeing more of that, I think.
Okay. Another comment, thank you for sharing, Maria. We definitely use the term feeder. We need to
Oh.
reevaluate our terminology. When you know better, you do better. We even have a section called the feeder table.
Ah,
So yeah.
maybe the dependent dining table or something like that. No, I encourage you to come up with what works for you. I read that phrase dependent diner from a nursing aide who had helped a gentleman with his lunch. And I'd read the note right before I went in to see this gentleman. And I thought, oh, dependent diner, that's great. I love it. So I try to pass that on to people. But
Going back to the earlier issue about feeding tubes and RCFE, yes, you need a waiver or an exception from DSS, which is what I had thought.
okay.
Okay, we have lots more questions. We're at 12:33. If you logged on time, you can feel free to leave if you must, but we encourage you, of course, to stay because we've got some fascinating questions. What is, for a person with dysphagia, are they allowed to have ice cream due to the fact that it melts and would become liquid?
This is a big question among the speech pathology world. Some people say no, some people say yes. I think if someone's on thick and liquid diet, for example, I think it's probably okay to give them ice cream because you're probably going to eat it before it completely melts. And when it melts, doesn't melt into a thin liquid. You know, it still has a little bit of texture to it. But I would say, you know, if you have someone a speech pathologist in your facility, go by their recommendations. But there's also something called a magic cup, which is a dietary supplement, and it's a frozen thing, but it doesn't completely melt. Like even when it softens at room temperature, it's still like a puree texture. So you might look into magic cups. Those are a
Magic
good
cups.
alternative.
Great.
We use them at the hospital, but I don't know. For me, I think ice cream is okay.
Uh, what job position is best when patient is having trouble swallowing?
You mean versus like chin tuck versus level? I'm guessing that's what that means. So some people benefit from having a chin tuck position, and it helps them more easily manage the food in their mouth as opposed to being lifted where the food might drip back and go down into the airway. So I say for most people, having chin level with the floor, if you can prop them up in that position, if you know, like for example, from an instrumental exam, if a chin tuck position helps to prevent aspiration, then I would definitely follow that guideline. But chin level or down, but not extended back.
Okay.
And you might need to get creative with your pillows and cushions and things to attain that.
Okay. Um, what do you think of lemon glycerin swabs?
Yeah, they don't take the place of oral care for sure, but if you want to use them to help moisten the mouth, if someone has like a really dry mouth, I worry that the lemon might be too acidic and might actually aggravate that condition. Yeah, or you could maybe wet them or, yeah.
Okay. Someone said maybe use a finger brush like the ones for babies.
Hey, if that works, yes, for sure.
Okay. When someone loses their taste, what's the best way to increase appetite and encourage eating?
Yeah, that's a tough one. I think it's trial and error, finding foods that they like. Gosh, if they can't taste anything, that's
That's
a
tough.
tricky one. Yeah, yeah. I think just try a variety of things. Maybe offering something very colorful that looks appetizing might help. Or
Good idea.
some people, it's funny, some people as they kind of go through this process, they do really like sweet things. And if that's all they
Well, and
want to
our
eat,
Alzheimer folks sure do. Our Alzheimer folks really do.
yeah,
Okay,
yeah.
well, we just have a few more minutes, so I am going to see. Oh boy, there's so many questions. Again, I want to remind everyone that our speaker has graciously agreed to have you reach out to her by email, right, Maria?
Yep.
So if we didn't get to your question, don't be mad at me. I think people were a little upset last time. There were so many questions. So you can reach out to Maria with your question. Let's take one more question. Oh, and you just answered it. You didn't talk about tucking chin to prevent aspiration. So do you feel like you addressed that?
Yeah, and it's not like a general precaution. I would say it's very individual. It would depend on the person.
Okay. Okay. So one more then. What is the name of the item that you stick to someone's gums or teeth to hydrate the mouth through the night?
Yes, Xylamelts tablets. It's Xylimelts, I think. Xylamelts. It's over the counter. It starts with an
Okay,
X. I think it's
great.
Xylimelts. Yeah.
Okay. Okay, well, you can see there was just a great deal of interest in this topic. So we're
Yeah.
really thankful again that we had you on and appreciate all of your expertise. Again, thank you all for tuning in today for our topic. And please do join us next month on Tuesday, August 11th. For Erin Light, who's going to talk to us about sundowning. As we leave the webinar today, you'll get a pop-up for your evaluation. Again, for those of you getting CEs, you'll have to complete that in order to receive your certificate. Thank you once again to Maria and to our sponsors, and I hope everybody has a beautiful rest of the day. Bye-bye.
Hi.